Hello guys, hope I'm audible and visible. Good evening Manpreet, how are you? Doing good? I think your exams must have been over, you must be preparing for FRC path, right? So welcome back everyone, and I hope that you got the fiasco of the next exam coming and the notification just faked. NMC has officially given a notification that everything, whatever is official, will be on the NMC website. So please do not panic. What came was not true, it is a fake notification, but still there's definitely a chance that next can happen this year. Let's go get prepared, that's all right. So from now onwards, whatever I have named as Pathology 360 discussion, I'll be going with few basic concepts, few images, few MCQs, IPQs, and also a quick look picture so that you can revisit and then you can go and discuss them, right? So today, as like you can see, I'm going to talk on intracellular accumulation. We'll have a very short discussion of intracellular accumulation. I want it to be as much interactive as possible, so I want you guys to comment on. And based on this intracellular accumulation, let's go and read about, let's say, like 5-6 MCQs. More of them are scenario based, so that you'll be able to solve the questions, right? Aryan, yes, I'll definitely follow this. Like we have a schedule of every faculty there, so whenever my turn comes, I'll go with Pathology 360 discussion. Fine, Aryan? Okay, so first thing is why I need an intracellular accumulation. The simple reason is I will not always get a tissue when there's a damage. So intracellular accumulation is nothing but it's an evidence of damage, be it necrosis, be it apoptosis, whatever it is, it's an evidence of damage, that's all. So by looking at this, I can say that there's probably a damage in the tissue, so it helps more for diagnosis. If you look in Robbins will classify them as protein accumulation, a glucose accumulation, or a calcium accumulation or something. But I want you to differentiate based on colors. See, because with next or NEET PG, the only focus or why you want to read pathology is identifying a few slides, solving a few scenarios, that's all. The colors distinction is much more easier than reading it as a protein or glycogen or whatever it is, right? So there are 4 different colors here. There are quite a few of you watching live here. I want you to comment whenever you see something clear on a microscopy. What's the first thing which comes to your mind? Whenever you see anything clear on microscopy, what's the first thing which comes to your mind? For everyone, clear. First thing I want you to think of, Aryan, glycogen can also be clear, but I want you to always think of this person, right? Fat. Lipids are always clear, right? Glycogen will become clear when it's very densely accumulated. Glycogen, I would say it's a more of a pink color appearance. Yes, like Dhanush said, like Manpreet said, it's going to be fat accumulation, right? Especially not any lipid. Fatty acids is not clear. It's only triglycerides which is clear. Okay, triglycerides which are clear in appearance. In addition to that, can I say mucin is also clear? Is that statement right? Just comment yes or no. Mucin can also be clear, right? I'm just going to write in corner which else can be clear in microscopy. Mucin can obviously be clear in microscopy. If it's in water, hydropic degeneration, water obviously will be clear in microscopy. And like what Aryan said, glycogen can also have a clear appearance whenever the accumulation is going to become more dense, right? So I'm just writing glycogen with a question mark nearby, because for me, I wanted to pick up pink color as glycogen, but yes, sometimes glycogen can also have a clearish appearance, especially in a seminoma or a dysgenoma slide, or in a kidney biopsy in diabetes. You can have a clear storage of glycogen as well, right? But here it's fat only. Now again, we are going to go back to your basic template. If I am seeing something in microscopy which is clear in appearance, can I differentiate whether it's mucin or water or glycogen or fat? Is that possible for me to differentiate it? If you have different appearances, is that possible for me to differentiate it, or possible for you to differentiate it? You cannot differentiate, right? I will not be able to say there's a clear fat or a clear mucin. For that, I need only one person, which is special stain, obviously, right? So without special stain, nothing is going to work. So our goal is simple thing. I need to differentiate them what it is, and based on the appearance of special stain, I'll say, okay, this most probably fat, or most probably a mucin, or most probably a water, or most probably a glycogen, right? That's our basic template here, right? So now tell me, I'm sure everyone here can answer this question, and I want you to answer the question. If it's wrong, ignore, chuck it. It's fine. What's the stain for fat? Everyone knows the answer here. I'm sure you know more than one stain. Whatever stain comes to your mind, answer it, right? So for me, here my goal, intracellular accumulation, is fat. Yes, Sudan black B. I want you to know that SBB is the other name for Sudan black B. You should not get stumped that, okay, this question is SBB. I don't know what is SBB. SBB is Sudan black B. Not just Sudan black B. Anything which comes in Sudan black. It can be Sudan black B. Sudan black has multiple things. It has 4, it has 5, multiple numbers. Anything with a prefix of Sudan black is a fat stain. Remember that, right? And like Manpreet said, there's one more thing as oil redo, right? Okay, oil redo. So now let's go back to a basic question again. I asked this multiple times in a lecture. Why is fat clear in a microscopy? Yes, you are right, PPP. Why is fat clear in a microscope? Because fat grossly has an yellow color. You must have seen fat in the naked eye, right? It's yellow in color. But in microscopy, it's clear. Why? Because this also is an MCQ point of view, because fat will be washed away during processing. It'll be washed away when you process a slide. Processing in the sense, I use alcohol, I use formalin, I process a slide before I look them into the microscope. You have a solid tumor, I have to cut them and then process them and make it, right? So it'll be washed away during processing. So fat generally gets washed away. That's the reason fat is clear in microscopy. Now I'll show you an image. I don't have an image, I'll show you an image soon. So if you see fat in microscopy as a clear area, right? I'll show you an image in an MCQ what we have in future, right? This, let's assume this is. In this place, listen carefully and answer. It's an empty place or it's a fat? Is it empty or fat? It's obviously an empty space, right? It's not fat. Fat was present here because fat is getting washed away. I'm seeing this. Now, whatever you said, Sudan black B, Sudan black 4 or oil redo, whatever it is. If I do Sudan black B or 4 or oil redo in this slide, will it be stained positive or not? I'm doing in this slide Sudan black B. Will it become black in color or not? That's a simple question. It will not become black in color. Just now you said, Dhanush and Manpreet said that it's empty, right? It's empty. So empty thing, whatever I stain, it will not become black in color. Perfect, right? So this brings to one more question, which is as an INICET exam, a fat stain of Sudan black and oil redo. Can I do them in a formalin fixed section? I'm taking a normal biopsy fixed with formalin. Can I do Sudan black or oil redo in a formalin fixed section? The answer is simple. You cannot do, right? So the fixative is going to be different. The fixative for the fat stain, the Sudan black oil redo is completely different. The fixative here, it should be a frozen section. Only when it's frozen, this processing is not there. I'm not going to process the tissue. So obviously I can easily diagnose them. It has fat, right? This is important. This came in MCQ. Remember, don't jump and say it's formalin, because formalin is something which always we remember, right? So here is not formalin. It should be frozen section or a saline. Unfixed tissue is the only place you can demonstrate fat, right? Next, what all comes to your mind when you think of pink color? Anything which comes to your mind, because I'm going to extrapolate to whatever you say, right? Learning is always mutual. You give me some point, I'll make it bigger and give it back to you. That's all. Tell me whatever comes to your mind, which is pink in color in a microscopy. Anything. Aryan, that's a very good question. I'm sure you know the answer as well. It'll be yellow in color, right? Okay, I'll take whatever Manpreet and Dhanush said, glycogen. Okay. Anything else? Perfect. Amyloid. Anything else which can be pink in color? Like I said, I want your participation. More you participate, more answer I'm going to give you. That's all. Okay. Amyloid. Again, a question I'm going to ask you to again. Can I say amyloid is a protein? Are amyloids protein? Yes, amyloid is protein. So can I say every protein can be positive for, will be pink in color? Obvious, right? It's a protein. So I just took your term and I made it a protein. Anything which is proteinaceous will be pink in color. Glycogen will be pink in color. Glucose will be pink in color. Amyloid also will be pink in color, right? So what happened is all these unfortunately are PAS positive. PAS is periodic acid shift, and all of them are PAS positive, be it glycogen, be it amyloid, be it protein, they are absolutely PAS positive. So when something is PAS positive, and what I have to do is I have to do one more modification to say it's glycogen or amyloid or protein, right? So what happens is if it's glycogen, it's called as PAS positive. I want you to remember this forever. And PPP, I'll take your term of hyaline, just give me a second. And we have something called as a diastase enzyme. I'm sure you must have heard about this. Diastase sensitive. Because diastase is a disaccharidase. It is sensitive for the diastase digestion. So diastase sensitive, it's your glycogen. PAS positive, diastase resistant. I'll write DR for diastase resistant. It's protein, right? Okay, hyaline. Okay, can anyone help me and PPP to learn what is hyaline? See, it's going to be a team effort. Without a team, nothing moves in this world. What is hyaline? When will you use the term hyaline? I just want your answer. Anything, if it's right or wrong, doesn't matter at all. When will you use the term hyaline? Because hyaline is also pink in color. Hyaline membrane disease, right? It's also pink in color. When will you use hyaline? Hyaline, if it's in combination. Perfect. It's a combination. I am not sure of what it causes. Okay, only then I call it a hyaline. If something in a combination got a pink color, because like each time as well as it's okay said it's cartilage. Yes, hyaline is a cartilage, but I don't know what caused the pink color in hyaline cartilage. Is the proteoglycans or the protein component in the cartilage which caused the pink color? I don't know. So use the term hyaline. If it's a combination, for example, in lung ARDS, hyaline membrane disease, can I say in a hyaline membrane disease, the pink color can be due to dead cells, fibrin, dead neutrophil? Yes, I use the term hyaline, right? I definitely use the term hyaline. Anything, if it's a combination, hyaline arteriolosclerosis, anything in plasma protein can get deposited, I use the term hyaline, fine? Perfect. Aryan, that is the bacteria, right? The bacteria is pH positive diacetyl. It's the right question. Can bacteria be made of protein? Bacteria can have protein, right? It's a bacteria, that's how it's positive. So it's a totally different context. Here, if it's not a living organism, it's a protein accumulation, I use diacetyl resistant here. pH positive diacetyl resistance for Whipple's also. That utility is totally different. We'll see that when we come to discuss about Whipple's disease, fine? Okay. So this is how a pink color deposit looks. It's actually an amyloid deposit. Though I am sure 100% everyone knows here, I don't use PA stain for amyloid. What's the stain we use for amyloid? Quickly, I want you guys to comment quickly. Fast finger first. What's the stain for amyloid? Everyone here knows the answer, right? The stain for amyloid is your Congo red. We use Congo red, we use the polarizing microscopy for amyloid. But yes, amyloid is also pH positive because amyloid is a protein. That's all, fine? Perfect, okay. Next is blue color. There's only one person who can be blue in intracellular accumulation, which is calcium. What's calcium? There are two different types of calcium, and I want only one learning thing from the two different types of calcium. One is dystrophic calcification, the other is metastatic calcification, right? Okay. Just only one thing I'm going to ask here. In which of these two types of calcification, dystrophic or metastatic, the tissue will be abnormal? In dystrophic or in metastatic? When do you think the tissue goes abnormal? In which of these two tissue will be abnormal? Perfect. I want you guys to answer. Which of these two tissue will be abnormal? In dys. Dys means abnormality, right? Here, the tissue or the organ where I see the calcification will be abnormal. So what do you think is abnormal in your metastatic calcification? What is abnormal in metastatic calcification? In one tissue is abnormal, right? In metastatic, it's meta, change in homeostasis. Here, the abnormality is calcium metabolism. Yeah, you're right in calling it PTH increase, but I'll say it's a calcium metabolism, that's all. In dystrophic calcification, tissue is abnormal. In metastatic calcification, calcium is abnormal. Again with this, there's one more question based on this. In which of these two do you think serum calcium levels will be elevated? Dystrophic or metastatic? See, if you know this tiny change, you can easily answer the questions. Where do you think serum calcium levels will be elevated? Perfect, it has to be in metastatic calcification, right? That's all, right? Whatever be the thing, microscopy, both of them will look pink in color. I cannot differentiate them on microscopy. Both of them will be blue in color only, right? These are calcium deposits. One more easy thing apart from blue color for calcium is, can I say, how many of you accept that it looks like these tissues are broken? It's not a very smooth tissue, right? It's been like broken, it's been like destroyed. Because calcium is very hard. So when I cut and make a slice, it'll get distorted. Calcium will most of the time be distorted. It will look separate from a normal tissue and little bit basophilic color or a very dark pink eosinophilic color. That's how calcium looks in a microscope, right? So there are multiple things that are blue in color. Calcium is one, nucleus is one. I cannot differentiate, so I need stain. What's the stain for calcium? There's one stain for calcium which is commonly used, which is 1-CoSA stain, right? That's a stain for calcium. Okay, Aryan, it's not actually pink in color, it's blue in color only. What happens is most of the slides which have been taken are stored for years together. It slowly fades. If you take a fresh slide of calcification, calcium looks a little bit basophilic in appearance only, it will not be eosinophilic. Even here, it kind of looks like very darkish blue shade, right? It's this thing here, right? PPP, I kept that for question, that's why I didn't say. So remove the comment so that you make a mistake in question and we learn more in the question, fine? Okay. Then black. What is black? There are only two things that can be black in color, and I want both of you to comment on. Anyone here, I want you to comment both. Which are two things that can be black in color? I'm sure you know the answer. There are only two things which can be black in color. One is coal workers pneumoconiosis. Manpreet, melanin is brown in color, right? No, melanin is brown in color. When it becomes very dense, it becomes black in color, right? Formalin pigment, yes, you are a PG, so I'll ignore that from, leave that part. Coal is definitely black in color. Since Manpreet said that, I can add that as well. There's something called formalin pigment. Formalin pigment can also be black in color. Maybe this is a bit high-fi for an undergraduate, but yes, formalin pigment can also be black in color. Tattoos can be black in color. Tattoo can definitely be black in color, right? And one more thing, this is especially for an MCQ point. There is one disease. Let's see how any one of you can answer. One disease which can cause congenital jaundice, which can have a blackish color in the liver biopsy. Can anyone name what disease it is? Black color, liver biopsy, one disease. In liver biopsy, if you see a black pigment, perfect. Think of a disease syndrome called as Dubin-Johnson syndrome, right? Here it's actually like an alkaptonuria. It's not exactly black, it's also brown in color. It'll have the banana body is called as, it will be brown in color. Dubin-Johnson syndrome, in liver, you can have norepinephrine's byproduct, right, or lipomyelin byproduct that makes a black in appearance, right? These are the only things perfect which can be black in appearance. Rest everything will be brown color. Melanin will be brown in color. Alkaptonuria homogenesic acid will be brown in color. They might look black to naked eye because of the density of the brown pigment, that's all, right? When you look in microscope, hair pigment melanin will also be brownish in appearance only, fine? Okay, so what do you think this is? It's a skin biopsy, black color. What do you think caused this black color? I told you the causes: coal, tattoo, your Dubin-Johnson syndrome. What do you think would have caused this black color? Skin biopsy, coal or tattoo or Dubin-Johnson? It's tattoo, right? It's a tattoo pigment, right? It's a simple tattoo pigment. So tattoo pigment also will be deep in the dermis. It will be black in color, can be in the epidermis also, right? So this might not come in an example, but you have to just keep in mind, if you see a black pigment in the skin, most likely will be tattoo, because very unlikely coal to enter or Dubin-Johnson pigment to come to the skin biopsy, fine? Last but not the least, brown. Now tell me quickly what all things can be brown in color. There are 4 things at least I want you to answer. Multiple things can be brown, but at least answer 4 which can be brown in color. I'll take one from your previous answer. Melanin obviously can be brown in color. Press. You tell me what pigment, what can be brown in color. I'll tell you the stain for it, right? If at all there is a stain required, I will tell you the stain. The stain for it is Mason Fontana. Ishtan, that's a very good answer. Melanin, melanosomes will have the same melanin pigment, right? Melanin, that's a very good answer. That's what you have to answer in your university exam. Here we'll keep it simple. Ruth, bile will be yellowish brown in color. Yeah, it can accept it's brown in color, but yes, it's more of an yellowish brown. Might not be much required for me because bile is mostly extracellular condensation, not an intracellular thing, right? So since you're going with intracellular accumulation, I'm ignoring bile. Yes, otherwise that also will have the same color. Lipofuscin will be brown in color. Wear and tear pigment. There are 2 things which pathologically brown in color. Pathological iron deposit is called as, you must have seen this in real life, isn't it? Copper is brown in color. Perfect. I'll take Danish's answer. Copper is obviously brown in color. There's one more guy. Iron, right? Hemosiderin. Hemosiderin is also brown in color. Ferritin is also brown in color. I didn't include ferritin because ferritin is a physiological storage form of iron. It's not pathological, right? It's okay. Earwax, it's the destroyed cells, lipofuscin accumulates in the earwax, which gives a brownish appearance. That's all, right? Lipofuscin, any destroyed cell will have lots of lipofuscin here. And what's the stain for iron, hemosiderin? You know the answer. It's Pearl's Prussian blue. I'll just write Pearl's stain. Pearl's Prussian blue or Prussian blue stain or Pearl's Prussian blue means the same. Copper, I'll just name only one stain which I like a lot, Orsine stain, right? There are more stains as well. Now a question back to you again. Pearl's stain stains only hemosiderin or stains both ferritin and hemosiderin? Only hemosiderin or both ferritin and hemosiderin? You know the answer. Pearl's will stain only hemosiderin. Pearls will never stain ferritin, right? Remember that it doesn't stain ferritin, right? It stains only hemosiderin, which means it stains only the pathological iron. It will not stain ferritin. Keep this in mind, fine? It's a new information for you. It's okay. We'll learn it because there's no reason why I need to go and identify ferritin in a biopsy. Ferritin is a normal storage form, right? It will not stain ferritin. It will stain only hemosiderin. Remember that, right? So I know 4 intracellular accumulations, 4 different colors: clear, pink, blue, brown, and black, right? Brown and black are pigments, so I put as a single one, right? So based on this, let's go to MCQs. This is your brown color. These are called as heart failure cells. You see in the alveoli, hemosiderin, latent macrophages. That's all, right? Now a few questions. Read through the question. Maybe I'll keep myself mute for 20-30 seconds for every question, then you'll go ahead with it, right? Okay, good questions. First of all, I don't even do bone marrow biopsies, and when it goes into the macrophage, it's a destroyed iron, and I'm going to look at it in the macrophage. We look at the macrophage iron. In macrophage, it will be the broken iron from the RBCs. It will be like a hemostatin only. Ferritin, once it goes into the macrophage, it becomes free iron. If it's stored as ferritin along with a protein ferritin, I won't have that. In macrophage, the free iron, which are the only iron which is available to the RBC to utilize. So in macrophage iron, what I'm quantifying is the free iron available for the RBC to utilize. So that will be free iron, that also will be stained with a Pearl stain for sure. Fine. Okay, let's come back to this. Quick questions. I want everyone here to answer. It's completely fine if you make a mistake. We have to get used to scenario based questions. Once we get used to it, you'll know that it's simple for sure, right? Okay, I'll mute myself for maybe 10-15 seconds. Go and look at the question and comment. Okay, answers. I'm sure you know the answer. Karin has gone for A. Others, I want everyone here to comment. It's fine if you're wrong, just comment. That's okay. Right? See, it's okay is there for us. Like you have given us a positive push, we have to answer the question. 54-year-old, chronic cough, squamous cell carcinoma on the right lung. While performing some surgery in pneumonectomy, the surgeon knows hilar lymph node is jet black in color. Black is only one guy. It's always anthracotic pigment. Don't think of this, because lipochrome will not be seen predominantly in a lymph node. Even if it's lipochrome, it's brownish atrophy of the heart. It's not black in color. Meladin grossly can give a blackish appearance hair. There is no reason why a 0.5 centimeter node should have melanoma deposit in a patient with the squamous cell carcinoma. It's not linking, so it's not option C as well. Hemosiderosis in a lymph node is very, very unlikely, right? So option B, C, D and ruled out. The answer is your anthracotic pigment. This came in a NEET exam. Quite a few of students wrote melanin. Remember, melanin is brown. If it's deposited, it can result in a black lymph node, but the lymph node will obviously be enlarged and you'll have a primary case of melanoma for sure, right? Harshit, hemosiderosis is a condition where iron is in excess, right? That's what hemosiderosis means, fine? Okay, next question. I'll keep myself quiet for some time. I want many more people to answer this question. That's a simple question. This came in an AIMS exam. People feel that AIMS is a very tough exam. It's not a tough exam. It's just in our head, right? We think it is tough. It looks like it's tough. Which of the following is a fixative to demonstrate Sudan black? Sudan black is a stain for fat. It cannot be done in formalin because it becomes clear in formalin. So obviously the answer is D, your frozen section. Tell me, just few other options. Tell me, where do we use glutaraldehyde? I'll tell Harshit. Glutaraldehyde is useful for electron microscopic sections, right? Okay, it's used for electron microscopic sections. Harshit is a question, what is Boyne solution? Can anyone tell me where Boyne solution is used? Though it is not used these days, there's one place where Boyne solution is used. Boyne solution is used for, was used for testicular biopsies. Even these days, formalin is replaced Boyne solution because Boyne is a bit toxic. Testicular biopsies, we were using Boyne solution, right? RN, hemosiderosis, hemochromatosis, pathogenesis, symptoms, everything is same. Etiology for hemosiderosis, secondary iron overload like thalassemia. Hemochromatosis, mutation. HFE gene, HAV gene mutation is hemochromatosis. That's the only difference, fine? Okay, let's go to the next question. Read the question. I'll mute myself for a few seconds and let's go and look at the answer. Answers. Ishtam is gone for B. Okay. So C, sorry. Okay, I'll call you Baig. Baig is gone for C. Anyone else? Come on, I want you guys to answer. It's fine. If you make a mistake, we learn. That's all. Don't be afraid to making a mistake. A person who makes mistakes is a person who's going to grow and get the first rank for soon. Okay, BBAS has gone for B and C predominantly. Fine. Okay, A as well. Okay, let's read through the question and let's see. Please see where you made a mistake. Fine. 35-year-old had an injury. That's all. Right. Which struck him on the leg. Skin is not broken. Right. Skin is not broken. But at the same time, there's a 5 into 7 centimeter purple color at the site of injury. Am I right in saying that this patient has something like an hematoma formation? Is that statement right? Is the statement right? Hematoma formation can definitely be there, right? Perfect. So which of the following substances is most likely to be accumulated at the site of injury which produces an yellow brown color after 16 days of injury, right? So here I'm having a patient with an hematoma formation, that's all. So lipofuscin is unlikely because lipofuscin is not going to be there in hematoma, right? Lipofuscin is a wear and tear tissue, we'll ignore that. We'll straight away ignore that, right? Melanin also I'll ignore because hematoma has nothing to do with melanin, right? So it's just hematoma. What will happen in hematoma after 16 days, right? Now I'm going to ask you one more question. Let's say you are having hemolysis. Hematoma is nothing but hemolysis, right? Am I right in saying that the bilirubin will automatically go into the circulation? Will it be dissolved? Or will it wait for like 16 days? Bilirubin will be metabolized, right? Bilirubin will definitely be metabolized. Bilirubin will go into the plasma, it will be bound, it will go to liver, it will go off. Bilirubin accumulation, the greenish yellow color or the yellow color, right? It's not yellowish brown in color, right? If it's bilirubin, the color will be different. It will be yellowish, little bit of green color. How many of you have seen bile in real life? You must have seen bile, right? You must have seen bile in surgeries or something. Bile has a yellowish green in color. So if the question says yellowish green color 4-5 days after injury, go for bilirubin, biliverdin accumulation. It's bilirubin and biliverdin, right? So if it's brown in color, it's always hemosiderin. Can I say even in hematoma formation, the free iron which is in excess will be deposited back as hemosiderin? It will be because it's 5 centimeter purple color. It's a huge hematoma that stays back, right? So it's neither A, B or C. Whatever mistake you have done, note it. See why you did the mistake. I have given you the explanation, the right thought process. See where it went wrong. If you have a note, write down that so that you don't make the mistake again. Fine? Clear? If everyone clear, we can go to the next question. Okay, let's see. I'll mute myself again for some time. Let's discuss. Answers. Okay, PPP start. NEETO file has gone with A. PPP has gone with B. Come on, I want everyone to answer. Baig has gone with A. Aryan has gone with B. Okay, no one is going for C and D. Okay, fine, we'll see. 84-year-old person, complication from Alzheimer's, dies, right? Heart is small, right? If grossly an organ becomes smaller, what is the term we will give? Brain or heart or intestine or hand or anything becomes smaller. You call it hyperplasia, hypertrophy, metaplasia or atrophy. What do you call them? Simple term, what do you call them? You call them atrophy, right? It's a gross atrophy of the heart. So heart has gone atrophy and heart is brown in color. Here, cholesterol is not brown in color. Glycogen is not brown in color. So I can easily rule them out. I have only 2% which can be brown in color. In atrophy, and here the first option is hemosiderin with iron overload. Is there any history of iron overload here? 84-year-old person, Alzheimer's disease, dies. It's an old age. In old age, heart can definitely become small, right? It's cardiac atrophy, and any case of atrophy, you will see the atrophic pigment is a lipofuscin pigment. It's a wear and tear pigment. It's a pigment of cell aging. So that can definitely accumulate. It's not hemosiderin. 2 reasons. I don't have a history of hemosiderosis. If the same question says it's a 22-year-old person with liver failure, bronze diabetes, can hemosiderin deposit in the heart? Is that possible or not? Possible, not possible? It is possible, right? So it's not that it can never happen. It's possible. So my answer can definitely change based on the clinical scenario. I know both are brown in color. In this scenario, the best fit is obviously lipochrome. And if it's a different scenario, hemochromatosis or hemosiderosis, hemosiderin can be the right color, right? It's based on that. It's not always the right answer. It's always based on the clinical scenario, right? Perfect. Okay, great. Next question. Comment on this. Let's see if you can write the right answer. Okay, answers. Answers. Argamoni has started with tyrosine. Anyone else wants to add to it? It's a very simple question. Mostly the simple questions are the one which takes lots of time. C, C, C. Okay. The person has gone snorkeling for Andaman, right? Making us more jealous of that guy and spends a long time in beach. We also wish we had the time in the beach. Next day, there's a darker complexion. Skin doesn't show warmth, edema, or erythema or tenderness, which means it's fine. There's no inflammation here. Just change the skin color. It's nothing but which of the following biochemical process will come. What's happening here? Tanning. That's all right. Perfect. Maybe this is what they call as integration. You don't read about tyrosine causing melanin in your pathology. You read them in your biochemistry, but still you know it. See, when you say integration, it becomes much easier. So don't worry when the next exam comes and they're saying it's going to be more integrated. You'll have more logical application than memorizing facts. It's easy to answer an integrated question. It's easy to answer a 4-line question. It's very difficult to answer a 1-liner question. Memorizing is difficult. Here, everyone, you're very good in understanding and conceptualizing something. So it's fine. Next is doing good for you. Don't worry about an exam. Fine. Okay, next question. I want everyone here to comment. It's okay if you make a mistake. It's completely okay if you make a mistake. Amazing. See, again I said, reiterating my point, you guys proved a point that when I said this, when I showed this, most of you were right in answering the question, right? Most of you said tyrosine. Other questions, most of you did a very good job. But here, this is what one-liners does to you. I change it differently. PPP, you told that alizarin red is the other stain, right? Just few minutes back. Alizarin red is a very specific stain for calcium. This is what one-liners does. They play with words. That's very difficult to remember. So when it becomes scenario-based question, be happy. Your silly mistakes will come down. You'll score well, right? Alizarin red is a very specific stain for calcium. Alizarin red stains elemental calcium. I'll tell you what is the difference between alizarin red and von Cosa. It stains elemental calcium. Von Cosa stains calcium salts. Only when calcium is in the form of a carbonate or a phosphate, von Cosa will stain. And von Cosa is undoubtedly most commonly done stain because it's cheaper, that's all. Right? So if a question comes on specific thing, that's fine. So if a question comes on a specific thing, go for elemental calcium or alizarin red. Again, this is not done in the lab. This is what one-liners will do to you. It will make sure the very exotic ones they ask and they make sure that you are wrong. It's fine. It's fine if you make a mistake. We learn something today, like Aryan learned something today. It's fine. We learn new things on the go. If at all a question comes on calcium and more specific, go with alizarin red. Most common is obviously von Cosa. The only stain is obviously done is von Cosa only. Fine. One more question. Let's see if we can answer. Let's see, image-based question. Right. Let's see. Option. Answer. I'm sure you know the answer. Okay, Beg has gone for 1, Aryan has gone for A, others. It's okay, if you're taking your time, it's completely fine. Take your time, read the question, comment on the answer. It's completely fine. Dhanush has gone for 1 as well. Okay, now what I'm going to do is, I'm going to make sure how to attempt an image-based question. I will make sure that you will never ever make that mistake again, right? Let's cover the image. A liver biopsy of a 34-year-old woman. Okay, it's breaking stigma. It's completely fine. Long-standing history of alcoholism. Can I say alcoholism will have fatty liver? Yes. Do I even need this image? I don't need the image. I know that everyone here knows that alcoholism will cause fatty liver. If it's a fatty liver, we know that for sure it's a clear color thing here. It's extremely clear areas here, right? So any IBQ, the first thing what you're going to do is hide the image. Be it pathology, be it histology. If it's a spotter, I cannot. Be it pathology, histology, medicine, surgery, go the history. Because you're being tuned to diagnose patients with the history for 4.5 years. Suddenly when the exam comes, you cannot diagnose with MRI or CT or ECG. History. First history, then look at the options. Alcoholism, triglycerides, possible, fatty liver. then go and confirm the microscopy. Yes, microscopy has clear areas which is fat, right? Other things will not be the enzymatic fat necrosis will be there in pancreatitis, not as an alcoholism, and it's different. And by the way, necrosis will look pink in color. Even if it's a fat necrosis also in microscopy will be pink in color. It will not be clear, right? It's always any necrosis will be pink in color only. Only a normal fat triglyceride will be clear in appearance. Option A is the right answer here. Fine. Okay. One more question. Let's see if we can answer. Keep myself quiet for some time. Just after this, there's one more question. That's all. Very close things might you think you might miss, but read the options very carefully. You will definitely know the right answer, right? Breast cancer, widespread bony metastasis, right? I'm having a patient with breast cancer. Can breast cancer cause osteolytic metastasis? It can. So if it causes osteolysis, will it derange your serum calcium level? Will it derange serum calcium level? Yes. So breast cancer is going to destroy bone. If it destroys bone, especially bony metastasis, it will cause elevated serum calcium. If serum calcium is elevated, dystrophic or metastatic? We'll go one by one. Dystrophic or metastatic? It has to be metastatic, right? So these two are gone. Simple. It's not a dystrophic calcification, it's metastatic calcification, right? Perfect. So I have only 3 or 4th option. Now metastatic calcification means elevated serum calcium level should be there. It cannot have decreased serum calcium. This is also wrong answer, right? So right answer is option 4. So here I need to know what is the cause here. If you have given a straightforward question, metastatic calcification, which of the following is true, you will write it very simply, right? I have just given a history. It's a bony metastasis, or I can have the same history as multiple myeloma, or I can have the same history as hyperparathyroidism, right? So whatever history changes, the denominator is this guy. If serum calcium level is elevated, metastatic calcification, option is answer 4. Fine. I hope it's clear, right? Last question. We have seen through. I told 30 minutes. I've taken extra 10 minutes. I think it's fine. So the answer, let's see. It's just a play with numbers. It's very simple question. I'm sure you will tell the right answer. The question clearly says lipofuscin, right, as a substrate, and how it's formed. Adverse effects, someone is researching on that, that's all, right? Which of the following will have the greatest amount of lipofuscin? When you say lipofuscin, automatically age factor comes into the play, right? Obviously liver with 75-year-old person will have definitely more lipofuscin compared to a liver of a 15-year-old person, right? Like I said, it's a very simple question, a number play. It's a very simple question, but still we have been solving almost 9-10 questions together. The amount of attention in the 10th question compared to the first question, same or less? I want everyone here to answer, because there are quite a few people who have been consistently saying the right answers, reading the questions. The attention will definitely come low. If this is true, which means in real exam also the same thing can happen. So practice. If it's same, amazing. If it's less, practice more. Write GTs. Solve subject based tests. Make sure your attention stays the same for next 300 questions. If you do that, 200 questions, if you do that, you will definitely ace the exam. Fine. So thank you for your time. Hopefully in a few more, maybe in some more time, I'll discuss one more 360-degree pathology. I'll take a tiny topic, give a brief introduction about the topic, and then we will go, yes, saliva diastasis, Dhanush, and then we'll definitely go and solve questions about it. It is true, Dhanush. If you are in your medical college, you can go and ask the pathology class. Fine. Sure, Aryan. Fine. Thank you for your time. See you soon. Till then, bye bye from Dr. Ranjith. Bye bye.